Hi everyone, my name is Gregory. Today I would like to present a case called circuit preservation I just done in my office. I'd like to share with you the procedure what was done. The patient present in my office with the periapical abscess on tooth number 3. You can see on the 3D pictures there is a mesial canal, a root canal failed. There is also the fracture on the same tooth, a vertical fracture. If we looked on this patient, it's 3D. From this view, we can see that's how big the lesion is, and the good part is there is no sinus connection between the lesion and the sinus itself. So from another view, we can see how much the infection we have and how it spreads around. And let's check on this view. What we can see here, that's the borders around the bone around this infection is intact. So I have like a 5 volts intact in this area, and that's when I do the extraction. And from my point, I have to be careful not to break the remaining tooth structure. So this patient presented, it's number 3. From a occlusal view and the buccal view, there is a peri-probing in the bifurcation area. The patient a little bit has symptoms on bite on and off, but not present today. So on the next slide, what I want to show is I try to separate the roots. So when I pull them, I will not break any in the intact walls I have. So I want to save as much as possible around it. And also when I try to extract, especially in the front area, I try to not jeopardize the interproximal area. And I want to see in the picture on X-ray first how thin, how thick the bone is. If it's very thin, I have to be careful and try to extract from not from the buccal side, but from the palatal side. So to make sure I have intact area, especially the buccal wall in the proximal, where the aesthetic is very important. So in this case, I've been using a surgical round bore. I separate the palatal root from the buccal and separate 2 buccal roots from each other. So when I luxate, those roots are removed, and I've explained earlier, trying to with a peer probe to see if all walls are intact, and also measure the socket size. If I wouldn't have a 3D picture, it will give me an idea what kind of implant and size I would probably place in 3 and 4 months after this area is going to be healed. So you can see here it's like 10 millimeters in length, and I have more than 10 millimeters in width. So pretty good, but I see that the infection was on the medial buccal root area. We remove the whole infection, so make sure there is no infection left. And I know that this buccal wall is very thin, and I know that I'm going to lose much of this bone, and nothing can be done to preserve it. It will shrink. So on the next slide, what I did, I used just cancel this bone, the size 0.25 by 0.5 millimeter, cancel particulate bone, and I use by Ace company. You can use something else by Puris. Somebody use Patty, but again, it's in this area, you don't have to use the most expensive material. The bone is going to heal because it's a 5 volts intact, and it's going to be a pretty good healing. So on the next step, again, I don't overfill the socket, I don't pack it so hard, so make sure I have enough blood supply. Usually bone grows millimeter a month, okay, but in this area, because 5 walls are intact, it grows faster, so you don't have to interfere with the blood supply in this area. I use color tape. Some people use something different material. I know Samuel Lee, who invent it's a sinus lift from the ridge. He been using like a rubber dam. Again, people use different stuff. Sometimes for aesthetic part, I've been using from the tuberosity the soft tissue, and I will use as a plug-in and get like a primary closure. Sometimes if this area or some of the areas I see that's a deficiency or the missing teeth and the deficient the ridge area, so I do socket preservation and the ridge augmentation at the same time and try to split the buccal ball and get the primary closure. But if I do just regular socket preservation, I don't split because I don't want to interrupt the blood supply from the periosteum to the buccal wall. So on the next slide you can see the picture before and a picture and after. I filled with a bone graft. You can see even in a regular picture it's very hard to see that even you have this lesion, but that's why it's a 3D, it's handy to check the area and it shows there is a big infection over here with a vertical fracture. Thank you.